All right. Good evening, everybody. I'm going to let you all take a quick second to join. While you're joining, you all know it's my favorite thing to do, my favorite icebreaker, which is to get you to use the Zoom toolbar there. Pull up that chat window and let us know where you're tuning in from today. I know we got tons of people coming in from across Canada just looking at that registration list. So type in the chat, let us know what city, town, province, territory, wherever you're tuning in from. While you do that, I'll introduce myself briefly. My name is Troy, and I'm the Director of Operations for Nurses Specialized in Wound Ostomy and Continence Canada. And I'm really excited to be introducing our this is our fourth NSWOC week event so far. Some of you I can see in our list so far here have been in attendance for some of our other great presentations, and this is going to be no different. Today I'm joined by Erin, who's going to be doing a fantastic presentation on wound cleansing debunked. And many of you, I think, in this list probably already know Erin, who's our core program leader for the community engagement core program. She's also incredibly involved with the Wound Ostomy and Continence Institute, whether it be an academic advisor for the NSWOC program or through a practice enrichment series, the director of our Spanish programs, which I'm sure maybe you can give a little introduction to during the Q&A portion or something, Erin, but very, very involved, and we're incredibly happy to have her presenting with us today. So without further ado, I'm gonna pass over the mic to Erin. Thanks so much, Erin.
Great, thanks, Troy. And thank you all for coming tonight. Many of you guys do probably know me. I've definitely been around the scene for a while and putting my nose in every possible place that I can. So for those of you that do know me, and for those of you that don't, wound cleansing is a passion of mine, the whole topic itself. There's a lot of, really interesting and fun areas in the specialty, and I think that's why many of us are so attracted to it. But I think for me, going back to basics and making sure that things are done correctly is sometimes very much needed. Sometimes we get really caught up in all of the, fun new toys on the market, and we kind of forget to go back to the basics. So the purpose of this presentation is that I'm going to talk about the evidence for wound cleansing for a bit, and it is going to go through not necessarily how to read evidence, but we're going to talk about the different levels of evidence. And when somebody essentially says, well, this is what the evidence states, or this is well evidenced, or will studies show this, we're going to kind of have a discussion about what that's all about and what is actually out there for this topic. Then we're going to look at different methods of wound cleansing. So we know that there's many ways to clean a wound. I'm not going to go into all of them, but I'm going to cover the two that are most common across care settings in Canada. We're going to talk about the different wound cleansing solutions. And if you guys saw this on the objectives and thought that I was going to go into super great detail about when and how and why to use them, I will disappoint you. I'm not going to go into, the minutia of cleansing solutions, but just to have like an open discussion about them and, what maybe they're good for, the evidence behind them. If you guys have questions at any time, feel free to go ahead and put your hand up or ask. There's a lot of products on the market now, and it can get pretty overwhelming and expensive. So when should we be using one versus another? And then we're going to look actually at the wound cleansing techniques that we talked about previously to look at optimizing the prevention of biofilm using those two cleansing techniques.
And sorry to cut you off. I just did forget to mention, everybody, if you have a question for both of us, do just use that Q&A button in your Zoom toolbar, and that'll make sure that Erin and I can see it, and we'll make sure to ask that for you. Sorry about that, Erin. Go ahead.
Oh, thanks. So during this presentation, I kind of wanted to just throw it out there and have you guys think about why is it actually important to cleanse wounds? If we do go to the literature and we bring up wound cleansing, there's a lot of documents that actually even just say it's ritualistic and there's no evidence to support the need. So some questions to think about and reflect on your own practice. When you go in and you perform a dressing change and you start by cleansing the wound, what supplies do you have? Do you question them? Do you even have rationale for what you're doing. So do wounds need to be cleansed with every dressing change? Maybe it depends on the type of wound. What actually influences your decision to use one solution over another? So put yourself in a scenario where you have the option, or you're responsible for ordering different solutions. What actually influences the decision? Does the method of cleansing matter? Between the irrigation and the swabbing and the different methods, is there an appropriate time to use one versus another? And are you actually taking the time needed to remove as much of that debris as possible? So I think we can all agree that healthcare, being a healthcare professional in today's environment is quite challenging with the time constraints and the limited amount of time that we do get with patients. So considering, you know, are we taking that time that's needed? So I want to show the hierarchy of evidence because research and evidence is not a huge part of nursing programs. And it's one of the areas that I feel can be extremely crucial to nurses practicing, especially when we're getting into a pretty expensive area of care. And wound care and the costs associated with managing wounds and wound infections can be astronomical. And we ask all the time for evidence, right? Nursing is an evidence-based practice. We should be making our decisions based on evidence. So what happens when we don't have that evidence? And so when you guys are reading studies that either the manufacturers are handing you or one of your colleagues is working on, this is the order of how, I guess, credible or reliable the evidence is. So a lot of the time, so systematic reviews are going to go through all different types of studies that are out there. All of those top ones kind of include a critical appraisal process. So somebody's actually taking the time to look at the methods of that study. Was it done properly? Did somebody consider all of the factors that could influence that outcome? And it's really got that rigor. Moving into the middle one, they can still be pretty good. So again, it's going to depend on those factors. But then when we get into wound care, a lot of what we have to go on is expert opinion. And expert opinion is still valid, and we have to rely on it because nobody takes the time or the money to put into these higher types of studies, but it is the lowest form of evidence. So we do have to be mindful when we're referencing things like best practice guidelines and all of those. Yes, it's in a guideline, but is it actually referenced with a study, or is it expert opinion, or where does this information actually come from? And so I like to bring up the RNAO best practice guidelines as an example, because here it tells you a lot of documents will follow this source of evidence. So it's got different grades. So is the evidence taken from the top part of that pyramid, the middle part, or the bottom part? And it's going to assign a level. And a lot of these, when we're putting sources or level of evidence to something, we're actually doing our due diligence and reading that whole study to make sure that it was done properly. So the RNAO best practice guidelines, which many facilities, not just in Ontario, but nationally, adopted because they were very well put together documents and guidelines at that time. So they were a credible source. A lot of rigor went into it. A lot of experts were involved, appropriate experts. And so they really were the guiding documents of their day. And when we look at wound cleansing in those documents, we come up again with a level 5 evidence. So it's really not very strong. So for a profession that is rooted in evidence-based practice, it's kind of crazy to think that the most foundational part of something that we do very frequently actually does not have any research behind it. So I let a couple people talk me into doing my PhD. Thank you to those people. And when I had to come up and with, a thesis topic, naturally I picked wound cleansing. So again, for those of you who know me, knows that I was a clinical lead for one of the home care regions in Ontario. And in doing that, and with a vendor previously, I worked with many industry partners, many clinicians, many specialists, all over. And I got a really good view of, marketing evidence, and all of those types of things. And what I started to see in home care is, again, there's time constraints. Staff are having to deal with more complex patients with less time. There's a plethora of products available on the market, and we're now seeing a shift into using some of those really high-end expensive products. We're seeing wounds become more chronic than they ever have been before. And that could be from a variety of factors. But going back, I really wanted to start establishing some evidence on those more basic methods. And if you look at the title, the very long title of my systematic review from the first project of my PhD, I want you to take note, because a lot of the studies that are published on wound care, the outcome is usually time to heal. So there's infection or time to heal. And we're going to talk about this later in the slide deck, but there's a lot of factors that can happen between those two steps, right? And so what I really wanted to look at was the direct impact of cleansing. So, what can we actually measure when we're cleaning the wound? Well, we can look at the amount of exudate. Does it cause bleeding? Does it hurt? Infection rates. So trying to look at the things that are actually a direct outcome of the intervention. And we found that there really wasn't that much out there. So current practice, about 15 years ago, we switched to irrigation. Traditionally, for many, many years, wounds were cleansed with saline soaked gauze and white, a very aseptic fashion. And then it was believed that we were doing more damage than good and removing healthy tissues and damaging healthy tissues than not. And so it was determined that irrigation was a sufficient method of cleansing, and it was going to be safer. So it wasn't going to harm the healthy cells and didn't require as much, I guess, education or experience in wound care. And so when we look at the factors that influence this change, again, we're going back to expert opinion. And while it's still valid, I mean, experts work with hundreds of people, and we see things, again, this is 15, 20 years ago, nobody's taken the opportunity to actually do the research, right? We've implemented something and we have no idea what the outcome is 15 years later, despite many people stating that there's no evidence and this is an area that really needs to be researched. So taking a closer look at the two main methods of wound cleansing, we have irrigation, and this is done a number of ways. And anything that is intended to wash out an organ or a wound with a steady stream of fluid is irrigation. And we see it actually across multiple areas in life. But we need to also consider the recommendations against the evidence when we're looking at irrigation. So some of the literature will state that the recommended pressure is 4 to 15. Some actually say 10 to 15. It can be quite variable depending on the document that you're referencing. But for the most part, the literature talks about less than 4 being able to is not sufficient to remove the debris, and greater than 15 can damage the healthy tissue. And when we're thinking of irrigation, the most important thing that we have to think about, the whole purpose for irrigation is that the force, whatever is best, needs to be greater than the force that is adhering that debris or bacteria to the wound bed, okay? So those things are connected together. That force has to be strong enough to break that bond. A lot of the evidence talks about using a 30 ml syringe with an 18 gauge IV catheter or 19 gauge or irrigation tip. You know, just looking at the components, the pressure is going to change dependent on the size of the syringe and the diameter of the needle. So again, there's not a whole lot of evidence out there to support one over another. In doing a search, I was able to find that a pressure of 13 was actually most effective. And there is somebody that did actually study the different combinations of syringes and needles and found that a 20 cc with an 18 gauge needle actually achieved, I think it was 12 PSI. Whereas the 35 ml syringe with the 19 gauge actually delivered a stream of 8 PSI. And again, I'm sitting here saying this, but things that you want to consider are, okay, well, how did they measure that pressure, right? So when somebody's talking and telling us something, or we're reading something as a result, we need to go back and look at how that result was achieved and does it actually apply. We're also going to consider the type of wounds. So I'm familiar with Ontario, so in home care, and pretty much across the board, there's some areas that will use the syringe and the needle, but there's a lot that have moved to those saline bottles. And so what happens is it kind of takes the decision out of it for the nurses performing the care or the healthcare professional. So typically you want to go in and assess that patient and make a determination on which method is going to be most effective. And in a lot of areas, that decision's been made for us through standard supply delivery and equipment. And there are going to be situations where irrigation is absolutely not indicated. So looking at swabbing technique, and this is going to be your saline soaked gauze, you can call it wiping, dabbing, any type of physical friction to that wound for the purpose of removing the debris. And both methods can actually be considered debridement, right? So if we look at the definition of debridement, debridement is the removal of non-viable tissue or debris from a wound bed. Well, that's exactly what we're trying to do by cleansing a wound, and we're using some type of force to do it. So when you're thinking of wound cleansing, or when you're teaching, you know, a novice nurse to do wound cleansing, it really needs to be made clear that there has to be that force to remove the gunk, or there's no point in doing it. In order to do swabbing, again, practice was changed because there was damage to healthy tissue. So we need to know the tissue types. You need to become familiar with the different types of slough, what needs to be removed. I've read documentation over the years. I've seen, you know, nurses document that they've removed pseudoskin, and I just worry that those are new epithelial buds. You know, partial thickness wounds, we can get those epithelial buds coming out from the hair follicle. So we don't want to be removing those. And sometimes it's hard to tell. So we really want to make sure that we know our tissue types when we're actually applying pressure ourselves to the wound bed. And that's because all of us are applying a variable amount of pressure. It can't be measured in swabbing because every person is different, and it's controlled by a human, not a machine. And it's also not used much because it does usually require additional supplies. So usually it was your standard dressing tray plus the saline, whereas the saline irrigation bottles is simply that. But keep in mind, wounds were cleansed this way for many, many, many years. right? And we were not seeing the problem or the wound chronicity that we're seeing today. And why is this important? So again, it's really hard to, present on such a basic skill because we're all professionals. We've all gone out and done this for, a number of years. So we kind of sit there and think like, well, this is the easy part. I don't need education on it. But the reality is it has a huge impact. Something so basic can create a huge impact. That patient now is developing a chronic wound and they're staying on service for a very long time. Our length of stay on service or admissions related to chronic wounds is becoming longer and longer and longer, which can have tons of mental health impacts on that patient. The longer the wound is there and the more times that we're in it, there's a potential for infection and need for antibiotics. Once that person gets to intravenous antibiotics, then it becomes a massive cost to the healthcare system. It's really putting a strain on our agencies and our organizations. We do not have enough nurses and healthcare professionals at this time. And so when you're giving, I guess, like substandard cleansing and creating these issues, it's really putting a strain on health system resources. And for the system, the costs are in the millions, usually provincially, for the cost of wound care. And that's not even considering the cost of wound infection. So remember, look at all of those diabetic foot ulcers with the osteomyelitis, cellulitis, wound infections. That's the cost of now an infusion pump rental, tubing, the antibiotic, and all of these things. Okay, we don't really think of those as costs, but that's all part of it. Are there any questions? Can I stop?
Yeah, so actually maybe we'll go just this was kind of on the irrigation and swabbing technique slides here. Someone was just asking, they work in a home care agency and they're told not to irrigate at all. And they're only allowed to use the saline soaked gauze. How can they ensure that they're applying the appropriate pressure? And I know you were just talking about pressure a moment ago. Could you touch on that maybe a little bit?
Yeah. So that's actually good. And I say that because, and it comes back to scope of practice. So in Ontario, for example, scope of practice is very specific. Okay. A registered nurse can initiate and perform irrigation. A practical nurse actually requires an order to perform irrigation. So I know that when I was the lead in the area, I actually advocated a lot to bring back the dressing trays because we were actually putting nurses in positions where they shouldn't have been in. And because I would say there's a lot of situations where we can cause further infection with irrigation. So when you're thinking of the amount of pressure to apply from swabbing, what I would suggest is, again, you take the time to know the tissue types. And you're going to really want to be able to identify new epithelial cells. Okay. We're not pushing hard enough to cause bleeding unless the wound bed is friable and it's not super healthy, then it may. But you're going to want to look at those factors. So, what's the pain? What is the exudate like? So with irrigation, it's kind of easier to tell with the exudate because we're irrigating until that fluid runs clear. We don't have that indicator for swabbing. So, and there is no way to measure how much pressure you're doing. So you've kind of, that's why it's important to think about all of this. Am I using enough force to dislodge, the stuff that's on there without harming that tissue, the healthy tissue underneath? And it is challenging. And so know your tissue types, and not just the type, but also the subtypes. So slough, for instance, are we going to remove adherent slough with a piece of gauze? Probably not. But that loose slough on top, do we want to go until we can remove all of that? Maybe.
Perfect. That was a fantastic
Hopefully.
answer, and thank you so much. The person is also just asking a little bit of a follow-up question. You mentioned the scope of practice at the beginning of your answer there. Could you just give a quick little distinction, I guess, on the scope of practice between an RN and a practical nurse when it comes to irrigation? So, for example, if they were an LPN an LPN and a SWAN, do they still require an order to do the procedure? Is that something you could touch on?
I can touch on it. I can't really give an exact answer. Again, I'm only really familiar with Ontario because I've done a lot of work to make sure the nurses are working within their scope of practice to protect themselves. In Ontario, if you go, I would say go to your college guidelines. So in Ontario, we have the College of Nurses of Ontario. They have very specific guidelines. So here it would be the authorizing mechanisms guideline in one of the appendix, and it actually has a chart of exactly what a PN and an RN can do. These guidelines we also have to consider are based on community, right? So now, you know, it's not talking about a hospital or long-term care where we get into different types of legislation and different types of scopes, right? So we have our provincial scope, our organizational scope, and then our independent evaluation of knowledge, skill, and judgment. Additional courses are absolutely great. It's going to give you a lot more knowledge and ability to assess the appropriate stuff. It's not going to change the legal aspects of the scope of practice. So in Ontario for practical nurses, they will, until legislation changes, and it is, but it's not changed yet. So I wanted to bring up that point. It will be changing. It's scheduled to change. We just don't know when. But the only things that a practical nurse can initiate is cleansing, soaking, and dressing. Okay.
Perfect. Well,
so sorry.
No, go ahead. I didn't mean to cut you off there.
So if when you're doing the SWAN program or any of the programs, connect with your team. It's really imperative to form those wound care teams within organizations so that you can go to the NSWOC and say, listen, I have this patient, blah, 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 blah. Here's the situation. Can I get an order to irrigate or, you know, stuff like that.
I was just going to mention, I think it was a great response, and I do see that we have, and I hope I'm not putting you on the stand here, Sharon. But Sharon, it looks like Sharon Hunter is in our chat there. I don't know, she's our SWAN Community of Practice lead. If there's anything you want to touch on, feel free to maybe use the chat tool there. Again, no pressure, but thought I would mention that. We don't have any other big questions in the chat so far here, so maybe we can keep moving on there. But I'll keep an eye out for you, and I'll flag you down if any big ones come in along the way. Okay.
Perfect. And if you're doing this SWAN program, absolutely get involved, please, in the community of practice. Reach out to Sharon. She is an amazing clinician and quite involved in that program. So now I'm going to touch on solutions. And like I said, I'm not going to get into the super big details of, you know, we're going to touch on the components. We're going to touch on marketing a little bit, and we're going to touch on, you know, the high level uses for it, and then kind of just have a discussion on when we should be using those new fancy solutions type of thing. So we're going to start with normal saline. Normal saline is 0.9% sodium chloride. It comes in a variety of packages, I'll say. It's the same solution that comes in the intravenous bags. I know some regions even have the patient make their own. It's literally salt and water, okay? This has been the standard of care for a very long time because it is an isotonic solution and it is physiologically compatible with our own bodies. And there's been studies for a number of years that have looked at, you know, saline and compared with sterile water, potable water, all of these things. I call them the cheap things. And this is really actually what I'm looking at in my studies, because again, we're getting into the use of all of these expensive products. And I'm a huge advocate for what is going to heal that patient faster. Absolutely. But when we aren't seeing those results and it's costing the healthcare system a lot more money, then we are the specialists. We are in the positions that we have to pay attention to these things, or our public health system is not going to be sustainable. And so I am spending a bit of time on the saline because one of the things, and this is with anything, that you need to consider is this being used properly before we move on to those other solutions, okay? When we cleanse a wound properly, we're going to be removing that gunk, that biofilm, all of those things. So what is the practice? How are you actually using these bottles or the syringe? Are you using them properly? I know that I spent a lot of time on the road with many home care nurses. I rarely saw somebody clean a wound properly with one of these bottles. Another big thing that I know happens across all care sectors, not just with these bottles, but with the like 250, 500 ml twist top ones, they are sterile products. And as soon as you crack that lid, it is no longer sterile. And, you know, now more than ever, many of you guys know that I'm working in Mexico right now with a very, very, very underdeveloped population. And to throw out something that's still useful is very, very difficult to do in front of these people. You know, they don't have the luxury of having a public system that pays for these things. But you have to look at the cost, okay? We're saving these thinking that we're, you know, saving the healthcare system money, or we're maybe don't have access to enough. Sterile saline develops bacteria or becomes a medium and grows bacteria within 24 hours. So if you're saving that bottle and going back and using it the next day on that patient, what you're likely doing is actually using a steady stream to deliver bacteria right into that wound bed and doing the complete opposite of what it's intended to do. And I know we're very cognizant of, you know, waste, medical waste, the environment, and we don't like to, you know, throw these out if there's still some left, but you really have to consider, again, are we applying the method properly? Are we using the actual product as it's intended? And if not, then you may actually be putting that patient at risk. Bosch. And I don't really want to be brand specific. So I do have examples of the different types of solution up. And sometimes I'll talk about the marketing information for some of the companies, but ultimately I kind of want to focus on the actual ingredient, okay? So Bosch is a newer solution to the market, although it's not a newer compound, okay? So this is a hypochlorous acid solution, which has been around for a long time and comes in many different strengths and different types of, well, different strengths and different compounds, I'll say. For years, we used, many of you guys will be familiar with Dakin solution, which is just a bleach solution. And that is what hypochlorous acid solution is. It is like a very dilute bleach solution. And again, we need to think about why are we using this, okay? Traditionally, the hypochlorous acid is used as a disinfectant. So if we have a wound with increased bioburden and we want to take some time to decrease that bioburden, then we need to move to something that's going to actually do that. When you guys are looking at solutions or when there's new products on the market, I really urge you guys to actually look at the label, okay? This product, for instance, contains water, sodium chloride, and the concentration of the hypochlorous acid is 0.033%. And I put a P beside it because a lot of these solutions that are on the market, the active ingredient that's promoted is actually that as a preservative. So whereas the normal saline, we talked about how it does not have a preservative, it's only sterile for 24 hours, it's going to grow bacteria. A lot of these more advanced solutions now have that active ingredient. The purpose of it, yes, they will work in conjunction with the other ingredients, you know, for the wound, but they're primarily acting as preservatives. So the hypochlorous acid concentration that's available is, in fact, to keep microbial growth contained with, or prevented from happening within the solution. Okay, and this is why it has an extended shelf life. I think it's up to 6 weeks or something, I can't remember. But this is a solution that we can reuse because it does contain the preservatives. So when you're looking at the solutions, check for that. It will typically say right on it whether or not it's preservative free or with preservative. And that is another way to know whether or not it is a single use item or it can be used for an extended period of time. And I just want to bring up some advertising, and I have for a couple products here, because we're going to talk about marketing material when I go through some of the solutions as well. So look at their websites and see exactly what the ingredients are used for as well. All companies are going to have products listed, and I find that we rely too much on, I'm not going to say we rely too much on expert opinion. We rely too much on experiential training. So again, we have orientation, we're mentored. A lot of people offer their practices. We kind of get into it. Figure things out for yourself. Go on, research these products and look and see. It tells you right there that it's a preservative. Again, it also complements the product and does have a purpose. But are we actually now knowing this, choosing this in the right situations? Anicept is another hypochlorous acid solution. And I did not change the, I guess I didn't save it. So it's not PHMB, sorry. It's hypochlorous acid, but at a different concentration. And so that's another thing too, is, you know, punch it into Google, which concentration is most effective for whatever you're trying to achieve. And usually there's some type of information. It may not be the most rigorous, but again, if it's what we have, then we need to use it. The next two that I'm going to talk about are traditionally our antiseptic solutions. So chlorhexidine, and we'll do povidone iodine next. Chlorhexidine has a reputation for being cytotoxic to wounds, which means that it damages healthy cells, and it can. So again, this is a product that comes in various concentrations. We have stanhexidine that's used very frequently, and that one is 2% and actually contains 4% of alcohol. One good option in home care, if you have access to it, are the chlorhexidine swab sticks without alcohol. So there's swab sticks that come in both red and green. A lot of the times it's on the infusion contract. Those green ones that are alcohol free are also 2% and come in very, very handy. We also have clinicians now starting to prescribe and use Paradex mouthwash. And I actually went to go look for some literature on it. And there's really not a whole lot available when it comes to wounds. But there's tons that's available in the dental industry, okay? And yes, this product is going to at least inhibit the growth or, you know, growth of new tissue. So we really need to be, again, cognizant of when we're using these. What is the goal of healing? Are we at a point where there's enough bioburden that we need to actually be realistic, stop healing, you know, use some of this or iodine and actually deal with the level of contamination, or what? It also gives us some insight into how long these products should be used for. Another big thing, we go in, we haven't seen someone in a while, something's done, the patient can't make it back to be reassessed, and these patients end up having their wounds cleansed with these types of solutions for months and months and months. Well, no wonder they're not healing. So again, we've got a plethora of different types of solutions that are out there. They all have their uses, and we need to understand when it's appropriate to use them, when not, and, you know, alternate between accordingly. Now, the Paradex mouthwash, and I'm sure for many of you guys that have done education with Dr. Sibbald, he's a huge proponent of this. And again, I don't know too much about it, but what I do know is that it's used extensively in the dental world. And the other thing that's extensively well known in the dental world is biofilm. So the dental industry has been using a lower concentration of chlorhexidine for many, many, many years to combat biofilm in the mouth. It just makes sense that it would work on tissue as well. And in lower concentrations, it's actually, from what is available, it's shown better to actually help with wound healing rather than inhibit wound healing. Povidone iodine, one of my favorites. I am a huge proponent of povidone iodine, mostly because it is a very broad antimicrobial. It's been around for a very, very long time and it's cheap. Is it cytotoxic? Maybe. It's a very controversial product. Are we going to anticipate amazing wound healing indicators with it? Maybe not. But again, what are we trying to achieve with that wound? So, you know, this is a great product for when somebody comes onto service and we have not established healability. We can use this. It is actually one of the most evidenced solutions at making sure that bacteria is managed. It does need to be applied daily, okay? And it is, and patients can be taught how to do it, no problem. But it is imperative to keep that wound as safe as possible before we know whether or not it's healable. And so this is a really good product to use to make sure that the wound's not going to get worse until we have somebody in that can make that determination. In wounds with higher bioburden as well, it's a really effective solution. So it's definitely one of my most go-to. And then if somebody has an allergy, and I'll use chlorhexidine. But again, it shouldn't, and none of these should be used for really more than a couple weeks max. So if somebody's got that high level of bioburden, I may actually say to them, okay, we're gonna postpone the whole trying to get it closed, and we need to deal with this bacteria in order to get back to that. And so I might take somebody and put them on daily povidone iodine for 14 days and reassess. And again, same type of thing. You want to reassess that wound and make sure that they're not staying on it, and that the bioburden is managed. And povidone iodine has been, again, around a really long time. It's simply water. You'll notice water is in most of these with the active ingredient. Actually, inidine, I want to talk about, sorry, I shouldn't say brand names. The iodine impregnated dressing is not necessarily a replacement for this, okay? It is, povidone iodine is an active ingredient, so it is going to provide antimicrobial coverage. And the nice thing about it is that it's a sustained release. But again, are we using it to manage bioburden, or are we using it to make sure a wound stays safe before we can determine healability? If we're just dealing with bioburden, then we don't necessarily, we can apply some level of moisture to it in addition to that povidone iodine. Whereas if we're actually trying to keep a wound dry and infection free, maybe we don't want that added Vaseline or paraffin that's used in these types of dressings, and then we have to use this. Prontosan is another really big one that's hit the market. And there's been lots of fun articles published on it. And this is one of my favorite ones to talk about because I find that there's quite a bit of misconceptions out there. So definitely, again, has its uses. My favorite place for it was on those patients with, venous stasis ulcers who had CHF and we couldn't compress, and those weepy edematous legs. This one, totally anecdotally and experientially, found that these people are prone to cellulitis and Pseudomonas infections, and this was kind of able to keep it at bay. Again, not any level of evidence to support this. The reason that I find this product confusing is because so many people refer to it as a PHMB solution, right? PHMB has also hit the market in the last years and become quite popular because it is a really good antimicrobial that does not cross into the dermis. And so people hear PHMB solution and naturally they think it's going to be just as effective. Again, look at the ingredients, okay? Right on the website, it will tell you that PHMB is that as a preservative, okay? The active ingredient is actually betaine, okay? They're all derivatives of each other, but that is actually the surfactant and the active ingredient in Prontosan. It is not PHMB. And if you look at the ingredients, this is actually, I don't want to say glorified contact solution, but kind of family and friends, I've always told them, if you have a little first aid kit, throw in a bottle of contact solution.
And do you mind if I jump in quickly with a question about that?
Yes.
Perfect. Caitlin was just mentioning when using the iodine for cleansing, are you using the full strength 10% iodine or diluted iodine, like weak tea colored solution or 1,000-to-1 saline to iodine concentration?
The most standard that's used is the 10% povidone iodine. Yes, it does come in various solutions. I actually went to the shelf here. I think I put it back. And actually just noticed that the povidone iodine here on the shelves is 20%. So 10% is the one that I'm familiar with using as kind of that standard. It's the one that's available in most pharmacies, in most care sectors. And that's the one that we know to be most effective at keeping that at bay. But again, I encourage you, punch it into Google. How effective are different concentrations of povidone iodine? See what's out there. Is there something that we could be using that's a little less strong, that's not going to be as, harmful to tissue, but still effective against bacteria? And really, that's what it comes down to when you look at these percentages, is how effective is it going to manage the bacteria versus impact the healing process.
Perfect. Thank you. Well, I'll return this back to you. We still got about just over 10 minutes left, so I'll hand it back over to you. Thanks.
Perfect. And so we just talked about this, but you can see again, if you take a moment and actually go to the website, look at, what's out there, look at the marketing material, it very specifically tells you that PHMB, this isn't the one, but it will tell you that it's there as a preservative. And I put in this slide too here because all of these solutions, when we look at the marketing material, they're all going to say the same thing. They're all going to say that they're 99% effective against biofilm or bacteria. They all eradicate biofilm. They've got lots of cost analysis studies to show that their product is going to reduce length of stay on service and save us tons of money. Companies will even put that they have a lot of clinical studies to support them. Actually go on and click on those studies, read them. You don't have to understand the, statistic analysis and all those fancy words. What you need to look at is how they measured things and does it make sense to us? You guys know what steps are needed. Is that what they did? Okay. Did they put it on the people that were putting it on? Or did they pick a population that was already optimized? And so when we consider actual evidence that they do have, so some of them again do actually have some studies, but we need to look at what those studies are. And not to say that, they're not reputable, some of them are, but we need to consider those different types. So we use a lot of consensus documents. Well, what are these? These are often based on a search of the literature, but they're also experts coming together to create recommendations. So there's a lot of really smart people there that are guiding practice. When we look at randomized control trials, yes, that's at the top of the pyramid, but let's look at the sample size. In order for a randomized control trial to actually tell us reliably whether or not it makes a difference, It needs usually an extensive amount of people. And a lot of the RCTs that we see in wound care are like 10 to 50 people. Is this going to be enough to actually change practice? No. And then there's many confounding factors. So confounding factors are all the things that can influence the outcome. So let's use the example of healing rates. So we have a study that shows that this solution heals wounds faster. Well, let's look at that study and let's look at those other factors. Were the underlying issues corrected? If yes, then how do we know which one was the reason, right? Yes, we cleanse the wound. What is the method that we're using? Was debridement a part of this? We all know how many wound care dressings are out there. What combination was used? Were all of these steps standardized to be the exact same so that, you know, we can kind of gauge nutritional status, mobility for venous leg ulcers, for instance. We all know the steps to take to optimize a wound. We need to consider what was done in conjunction to what they're saying, because if any one of these is optimized, then there's absolutely no way to say that it was one thing versus another. So going back to the current cleansing methods, and I'm just going to end with the actual techniques. So again, the purpose of cleansing really, and now we're getting into the biofilm-based wound cleansing. And I do encourage you to think about that. So again, wounds were never as chronic as they are today. And again, same thing. Can I say that it has to do with poor wound cleansing technique? No, because we do know that we have an aging population. We do know that patients are facing increased complexity and many more comorbidities as life expectancy increases. So can we say that, you know, it's practice that's causing all of this? Absolutely not. But it is something that we do have within our control. And again, going back to something so basic and remembering why we're doing it. Because if we can do the most basic parts effectively, even when we think there's not enough time, then we can prevent a lot of those other situations from happening that are consuming, you know, nursing resources and cost. So again, the whole concept of biofilm, and you can look at these little pictures on the screen and see how they're nicely attached to that surface. And again, remembering that whatever method that we're choosing, it needs to be strong enough to break that adhesion and get that up. And so another thing that you may want to consider is, unless we're using that or creating friction to lift that off, do we realistically think that we're doing enough to remove that biofilm? So irrigation, used quite extensively out there. Are you doing it right? So the steps for irrigation, you're going to have the patient and the wound assessment, of course. So right off the bat, you want to identify the wound type, the causative factors, and optimize those, okay? Gather supplies. You want to position the patient. So even the patient position is going to impact the result of that wound cleansing. And then personal protective equipment. Put it this way, if you are irrigating properly, you should be wearing goggles and a gown because you are going to get splashback. Make sure that you're including the peri-wound in wound cleansing. The biggest reason for wound infection, or the biggest cause of wound infection, is actually the skin flora migrating into that wound and overgrowing because we haven't done a good job of making sure the area under that dressing is cleansed properly. And then we're always going from dirty to clean, holding that tip, whether it's a bottle or a syringe, 2.5 centimeters from the wound. I just went backwards. Yeah. Anyways, pretty much those steps. And when you've got somebody on their side, so picture a person with, you know, a chronic pressure injury that is bedridden, and they're lying on their side for you to clean. Well, normally we would consider the center of the wound the dirtiest portion. So we would start there and work our way out. but consider how that fluid is also going to fall, okay? We don't want to clean the center, get it all free of debris, and then go up over top of it to wash the dirt and the germs from that peri wound back down into the wound. So we, again, need to think dirty to cleanest without it impacting or having the contaminants from the peri wound go back into that wound. I'm not going to play the video because A, I don't think it works, and B, but I'm not going to play it. For swabbing, same concept, okay? Go back to your days of nursing school, clean it, or dirtiest to cleanest. So you are taking that gauze, this is a linear wound, and you're going right into the dirtiest section first, throwing the gauze out, okay? Do not reuse a piece of gauze after you've wiped it. Also, I don't necessarily believe in using a gloved hand anymore. I tend to use the forceps. If you're using a gloved hand because you don't have access to a dressing tray, then make sure that you're only touching one piece of it and you're not squishing it in your hand and taking the contaminants. Those are not sterile gloves. So, you know, there's going to be organisms that are on the outside of those gloves. And again, making sure that you're not wiping the peri wound and going back into the wound. So starting in the center, one swipe, throw it out, and then working your way out. And we say the peri wound is about 10 centimeters outward. If you have a dressing that's larger, it needs to extend for the skin that is going to be placed under that dressing. And so again, with the circular wounds, we don't really have nice linear perfect wounds where we can just, so a lot of them are the chronic ones. And again, so the same concept, you're going to start dirtiest to cleanest, which is the center of the wound. And this time you're going to work in circular motions. And you're going to do one circle, throw out, grab a new piece of gauze, circle, and work your way out. And again with irrigation too, you can combine the methods, right? So maybe we want to irrigate from the center and go around, but we don't want to go as high as the peri wound on that one side because it's going to fall back down. So then maybe put some saline on your piece of gauze and clean that upper portion using gauze so that the fluid's not falling back into the wound. And so now I will take questions.
Awesome. Well, firstly, thank you so much, Erin, and that was a fantastic presentation. And thanks for answering the questions kind of intermingled throughout the presentation there. We do have a couple here. I know we just have a couple more minutes, or maybe just one more minute. So we'll see if we can get one more question in here. So a quick question about technique for cleaning a wound where you can't see or access the wound bed. If a patient with a chronic pressure ulcer about 1 centimeter depth, it is very narrow and can only fit a cotton tip swab. You cannot see the base. There is circumferential undermining with deepest undermining at 3 centimeters. How would you suggest it? What would be your kind of approach to cleaning this wound?
Great question. So again, thinking back of the method, if we have deep tunnels undermining, do we want to irrigate? So we have to consider, again, surgical wounds, you know, is the irrigation going to push that bacteria further into areas? And when we've got tunnels and undermining and all of these lovely crevices, then absolutely that can be a risk. So again, it's looking at the benefits versus the risk. Can we probe depth? Can we position the patient to make sure that that fluid comes back out? Because we don't want fluid sitting in there. Again, it's a medium for bacteria to grow. Wounds, the whole wound healing process is supposed to be quite natural and the body is supposed to take care of itself. We know that that doesn't happen. But again, don't be afraid to put your hands in the wound. I mean, again, don't, you know, be rough, but go as far as you can. If you can probe the base and get a cotton tipped applicator in there, again, just give it a little bit of friction. Generally, we don't want to be, you know, going too much into areas that we can't see. Tunnels, in my opinion, are probed way too often. They don't necessarily need to go down that far unless we have like stool in them or something where we know we need to get those contaminants out. Then it may not even be necessary.
Perfect. Well, thank you for touching on that. We maybe have an opportunity to answer one quick more question before we close out here. This one says, when irrigating a wound, is it best to go in circles? Is there a better method to use maybe when irrigating? What would you suggest?
So again, it depends on the wound. So typically with the chronic wounds and the round ones, so unless something is linear, then we're gonna go around. And again, I don't think because the center of the wound is typically going to be the most contaminated. And so what happens is if you're irrigating above that sector, there is no, I guess, gold standard way of doing it. So you could start at the top of that, do the whole thing again, and then just using a swab to do the top. With irrigation, you really want to make sure that for every area you're doing, that fluid is running clear.
Perfect. Well, thank you for touching on that. And I know there are still a couple other questions. We've unfortunately gotten to the end of our time. We got Journal Club coming up next during NSWOC week. But Erin, I want to thank you so much. And I'm going to reiterate what they're saying in the chat here. Nancy says, thank you for an awesome presentation. A fantastic teacher. Well done. Harley is agreeing, as well as Lena. Great presentation. Very interesting, says Marcy as well. And thanks so much to Cynthia. So without further ado, I'm going to wrap it up here a little bit. But before I do that, remind everybody that we have our final NSWOC week presentation tomorrow. That's going to be at 7 p.m. Eastern, 4 p.m. Pacific. That's going to be with Shirley McSavany, Catherine Cozell, and Diane Gard on leaving a legacy in wound ostomy incontinence, from developing a historical ostomy exhibit to lessons learned in a career well served. So thank you again, Erin. And I know we're all going to be on that one tomorrow. So we hope to see you there. And thanks for coming on tonight. We hope you have a good rest of the evening. Awesome. Bye, everybody.
Thanks, everyone.